Imagine going to the doctor with a severe, progressing physical condition, right? And finding out that as the structural damage to your body gets visibly worse, a completely different, like highly disruptive symptom you've been dealing with actually seems to magically disappear.
Yeah, it sounds like a medical miracle, like your body is somehow healing itself under pressure.
Right. But as we're going to explore today, that disappearance is a complete illusion. And treating the primary condition can suddenly and dramatically pull back the curtain on a devastating post-operative surprise.
It really is a dynamic that completely upends, how we typically think about disease progression. Because usually you just assume that as a structural problem deteriorates, all the related symptoms should just cascade and get increasingly severe.
Yeah, that makes sense.
But here, the local anatomy becomes so distorted that it actually creates a false fix, masking a secondary failure.
And that brings us to our mission for this deep dive. We are exploring a highly counterintuitive, deeply mechanical phenomenon in the female pelvic floor. So our core question for you today is, can chronic pelvic organ prolapse actually mask underlying severe stress urinary incontinence?
It's quite the puzzle.
It really is. And we have the massive stack of sources to guide us through this. We are pulling directly from the official clinical guidelines of the American Urological Association, surgical outcome studies, including the CARE trial deep dives into urodynamic research, and Peter Petrus's foundational book on the integral theory of the female pelvic floor. Okay, let's unpack this.
Sounds good. So to understand how one condition can mask another, we really first need to establish what is physically failing in the pelvis. We're looking at a complex hammock of muscles, ligaments, and connective fascia that basically hold the female pelvic organs. So the bladder, the uterus, the rectum in their proper suspended positions.
So pelvic organ prolapse, or POP, is what happens when that hammock just gives out. Like whether it's from the trauma of childbirth or aging or chronic heavy lifting. Those supportive tissues tear or stretch, and the organs just lose their mooring. They physically drop down into the vaginal canal.
Exactly. That is the structural collapse we're dealing with here. And we categorize it based on which organ is actually falling. Like if the rectum pushes forward, that's a posterior prolapse, or rectocele.
Got it.
But for our discussion on hidden incontinence, we are primarily focused on anterior prolapse, which is when the bladder drops. It's called a cystocele. Now, parallel to this, we have stress urinary incontinence, or SUI.
Which is the involuntary leakage of urine when you exert yourself physically.
Right.
You know, a woman coughs, laughs, sneezes, or lifts a heavy box. That action spikes the pressure inside her abdomen, and that pressure pushes down on the bladder, and the urinary sphincter simply isn't strong enough to hold the fluid back.
Exactly. That downward pressure overpowers the urethral closure mechanism. Now, if you apply standard logic, if a woman's pelvic floor is collapsing to the point of a severe prolapse, her incontinence should be absolutely terrible.
Right, you'd think so. The whole support structure is giving way.
Right. But in advanced stages of POP, specifically a severe cystocele, where the bladder has dropped significantly, that massive structural distortion alters the fundamental geometry of the pelvis. The prolapse tissue bulges and physically pushes against the urethra. It causes it to kink, compressing it right from the outside.
I'm picturing like the plumbing in a house, or even simpler, a garden hose in the yard.
Yeah, that's a good way to look at it.
Right. If you have the spigot turned on, there's pressure building up inside that hose. If the nozzle at the end is faulty, it's going to leak. But if you take that hose and fold it entirely in half, or, I don't know, step down on it with your boot, the water physically cannot get past the kink.
Exactly.
So the faulty nozzle isn't fixed, but the leaking stops anyway.
What's fascinating here is that kinking is the core mechanism of the illusion. It effectively protects the patient from leaking. I mean, the underlying weakness in the urinary sphincter is still entirely present, but the urine simply cannot force its way past the pinched urethra.
Wow.
In the clinical guidelines, this is referred to as a CULT, which just means hidden masked, or latent stress urinary incontinence.
So a patient will sit in the consultation room and honestly tell her doctor she doesn't leak when she coughs.
Right. And technically, her daily experience totally matches that statement. But it's only because her bladder prolapse is so severe, it has basically pinched the system shut.
Wait, if the prolapse is acting like a physical clamp on the urethra, what happens when a pelvic floor surgeon goes in to fix the prolapse? I mean, don't they just open the floodgates?
Yeah, that is the unintended consequence that makes pelvic floor reconstruction so incredibly fraught. A surgeon's primary goal during a prolapse repair is to restore the normal native anatomy. They lift the drop bladder, they tighten up the supporting tissues, and they put the organs back into their proper anatomical positions.
Which removes the boot from the garden hose. You're basically unkinking it.
The anatomical kink is totally gone. And a woman who was perfectly continent before she went under anesthesia wakes up, goes through her recovery, and suddenly develops de novo, meaning new onset stress urinary incontinence. The operation successfully cured her prolapse, but it entirely unmasked the hidden incontinence that the prolapse was suppressing.
That is just... If you're listening to this and you or someone you love has been told you need surgery for an advanced prolapse, the numbers on this are terrifying.
Oh, they really are.
Looking at the data from the colpopexy and urinary reduction efforts trial, the CARE trial, which was analyzed by Davenport and colleagues, this isn't some rare anomaly. The incidence of this new stress urinary incontinence scales directly with how severe the bladder prolapse was prior to surgery.
The statistics are heavily weighted against the patient. In the CARE trial analysis, women who had a stage 2 cystocele, meaning the bladder is dropping but hasn't quite reached the vaginal opening, they had a 41.3% chance of developing new incontinence after their prolapse was fixed.
Over 40%, just for stage 2.
Yeah. And for early stage 3, where the prolapse extends just past the opening, that jumps to 52.5%.
Wow.
And for advanced stage 3 or stage 4, where the organ has essentially everted completely outside the body, 66.1% of those women developed de novo SUI.
2/3 of women with advanced prolapse will start leaking after you fix the prolapse. I mean, the sources summarize this by saying roughly 1 in 3 women undergoing POP surgery overall will end up needing a second, completely separate surgery just to address the incontinence.
It's a huge burden.
I have to play devil's advocate here, though. If fixing a structural prolapse is going to trigger a massive incontinence problem for so many women, why are we fixing it at all? Doesn't the cure become worse than the disease? Just, leave the hose kinked.
I mean, it sounds like a pragmatic solution on the surface, but leaving an advanced prolapse untreated really isn't a viable option. Primarily because a kinked hose doesn't selectively stop accidental leaks, it stops intentional voiding as well. Advanced pelvic organ prolapse causes severe obstructive voiding.
Ah, I see. Because the urethra is pinched shut 24/7, not just during a sudden cough or sneeze.
Exactly. The plumbing is constantly occluded. The clinical data shows that up to 30% of patients with stage 3 or stage 4 POP suffer from urinary retention. They sit down and physically cannot empty their bladder no matter how hard they try.
That sounds dangerous.
It is. When urine sits stagnant in the bladder, it becomes a breeding ground for bacteria, leading to recurrent severe urinary tract infections. And if the retention is severe enough, the pressure backs up through the ureters and right into the kidneys, which can cause permanent irreversible renal damage.
Yikes. Plus, the daily physical reality of the prolapse itself. I mean, we're talking about a heavy, protruding bulge that causes friction, ulceration, and bleeding. It creates constant downward pelvic pressure, severe lower back pain, and often intense bowel dysfunction because that distorted geometry is dragging on the rectum as well.
The quality of life degradation is profound. The prolapse must be repaired to protect the patient's renal system and basically restore their ability to function. So, surgeons are placed in a highly precarious position here.
Yeah, I'd say so.
They have to fix the structural collapse, but they know doing so might unleash this latent incontinence. Therefore, before they ever make an incision, they have to engage in some highly specific diagnostic detective work to try and predict if the urethra will hold once it's unkinked.
Which means they need a way to simulate the results of the surgery in the exam room. They have to temporarily fix the prolapse without actually operating. And this brings us to the reduction stress test. Reading through the physical reality of how clinicians perform this was intense. The doctor asks the patient to come in with a comfortably full bladder. The standard guidelines specify around 300 milliliters of urine. Then, the doctor manually pushes the prolapsed organs back up into their proper anatomical position and asks the patient to cough.
Yeah, it is a mechanical test for a mechanical problem, but the execution is incredibly nuanced. The specific tools a clinician uses to reduce meaning to push up and hold that prolapse matter immensely.
What kind of tools?
Well, they might use a pessary, which is a firm silicone ring inserted into the vagina to prop the organs up. They might use large, firm cotton swabs called scopettes. Or they might use ring forceps or a split speculum, which allows them to hold the vaginal walls apart and elevate the bladder.
And the urologic nurses' guidelines heavily emphasize the danger of false negatives during this test. The clinician has to push the bladder up, but if their tool or their fingers accidentally press against the urethra, they ruin the whole test.
Exactly, and that is the critical variable that makes diagnosing occult SUI so incredibly difficult. If the physician uses a split speculum to elevate the cystosol, but the blade of the speculum presses flat against the anterior wall near the urethra, they have manually occluded the flow.
Oh, I see.
They've essentially replaced the anatomical kink with a clinical kink. The patient coughs, the increased abdominal pressure hits the bladder, but no urine escapes because the doctor's tool is literally blocking it. The test is recorded as negative for occult SUI, but the surgical repair, once healed, won't press against the urethra the way that a hard speculum did.
So the patient gets cleared, undergoes the prolapse surgery, and wakes up leaking anyway because the test was fundamentally flawed. It requires an incredible amount of physical precision from the doctor.
It really does.
Here's where it gets really interesting, though. Beyond the physical reduction test, the sources show a massive debate in the urogynecology community about another diagnostic tool, urodynamic testing.
Right. Urodynamics. It's an advanced, highly technical diagnostic procedure. It involves inserting tiny, pressure-sensing catheters directly into the bladder and the rectum. The goal is to measure the exact fluid pressures and muscle activity while the bladder is slowly filled with sterile water and then emptied. Some medical institutions and guidelines essentially mandate urodynamics before any complex prolapse surgery.
But a recent study from MDPI published in our source tech showed that performing preoperative urodynamics to predict if someone will leak after prolapse surgery is surprisingly ineffective.
Yeah.
The sensitivity of the test ranged from 0 to 44.4%. To translate that into real-world medical stakes, if a test has a sensitivity that low, it means it is completely missing the majority of women who actually have the hidden condition. It's basically a coin toss for predicting who is going to suffer from de novo incontinence.
It's startling data.
Why is a test that uses highly sensitive pressure catheters failing so badly?
The failure actually lies in the artificial nature of the test environment itself. Sensitivity, in a clinical context, is the test's ability to correctly identify those who truly have the condition. But remember the anatomical distortion we discussed. You have a severely prolapsed bladder and a kinked urethra.
Right.
When a clinician tries to reduce the prolapse to simulate the post-surgery state while simultaneously having a catheter threaded through the urethra, the catheter itself acts as a rigid stent. It alters the natural tissue tension.
Ah, okay.
So the pressure readings are being taken from an environment that simply does not accurately mimic the natural, uncatheterized postoperative pelvic floor.
The tool being used to measure the environment is physically altering the environment?
Exactly that. Because the geometry is so distorted, the urodynamic equipment cannot reliably recreate the unmasked state, which is why it misses so many women who will eventually leak. However, the MDPI study highlighted the other side of the statistical coin, the negative predictive value, which reached up to 98%.
Okay, so if sensitivity is about catching the people who will leak, negative predictive value is about the people who won't.
Right.
A 98% negative predictive value means that if the urodynamics test says you are not going to leak, you can take that to the bank. It is 98% accurate at ruling the problem out, which gives patients immense peace of mind, even if it's terrible at ruling the problem in.
It serves as a highly effective exclusionary tool. If a woman with a severe prolapse undergoes urodynamics with prolapse reduction, and there is absolutely no sign of leakage under intense measured pressure, the surgeon can proceed with the prolapse repair, feeling highly confident that they will not unmask hidden incontinence.
All of this diagnostic detective work, the speculums, the pressure catheters, the false negatives, it brings up a much deeper question. We've established how prolapse and incontinence interact mechanically like a kinked hose. But why do so many women have both of these profound problems simultaneously? Like, why are the structures supporting the organs failing at the exact same time the urethral sphincter is failing?
To answer the why, we really have to look at the foundational architecture of the pelvic floor and a major paradigm shift in how urogynecology views that architecture. Historically, the medical consensus blamed muscle damage.
We're like Kegels and all that.
Exactly. The prevailing thought was that if you suffered from prolapse or if you suffered from urinary incontinence, it was because your pelvic floor muscles were weak, atrophied, or torn during vaginal childbirth. But the sources point us to the work of Peter Petros and Ulf Olmsted, who developed what is known as the integral theory.
The integral theory shifts the blame entirely away from the muscles.
It fundamentally rewrites the biomechanical understanding of the pelvis. Petros and Olmsted argue that the primary cause of both prolapse and incontinence is not muscle failure, but the degradation of connective tissue, specifically the complex web of ligaments and fascia, like the pubourethral ligament.
I'm trying to visualize this structural shift. If the muscles are just the forces pulling on the system, but the connective tissues, these ligaments, are the actual support holding everything in suspension, is the pelvic floor essentially functioning like a trampoline?
The trampoline analogy is perhaps the most accurate way to visualize the integral theory. Imagine the vaginal membrane as the fabric of the trampoline.
Okay.
The pelvic floor muscles are the forces pulling on the edges, providing the tension. But the ligaments, the connective tissues, they're the metal springs connecting the fabric to the frame.
So if the springs on a trampoline become overstretched, loose, or broken, whether from age or trauma, it doesn't matter how strong the fabric is, right? It doesn't matter how hard the muscles pull on the edges, the trampoline is going to sag in the middle.
It will inevitably sag. And because the bladder, the uterus, and the rectum all rest directly on that vaginal membrane, when the trampoline sags, the organs sag with it. That sagging is the anatomical genesis of the prolapse. But the integral theory goes much further than just explaining the structural drop. It links that sagging directly to a cascade of severe urinary symptoms.
Wait, how does loose connective tissue cause you to feel like you need to urinate?
At the base of the bladder, embedded right in the tissue, there are microscopic nerve endings called stretch receptors. Their biological function is to act as sensors. They tell your brain when your bladder is filling up with urine by sensing when the tissue expands and stretches.
Makes sense.
But if the pelvic trampoline is constantly sagging due to degraded ligaments, those stretch receptors are being mechanically pulled and stretched all the time by the weight of the sagging tissue, even when the bladder is completely empty.
The sensors are being physically tripped by gravity, not by urine. So they are firing off constantly, sending false alarms to the brain.
A continuous, relentless false alarm. This premature nerve firing leads to a cluster of miserable chronic symptoms, sudden and intense urinary urgency, needing to urinate constantly throughout the day, waking up multiple times a night to go to the bathroom, and chronic, unexplained pelvic pain. Peter Petros categorizes this specific cluster of symptoms as the posterior fornix syndrome.
That makes so much mechanical sense. And it explains why surgical repairs that focus on restoring the tension to those ligaments, fixing the springs of the trampoline, can cure not just the physical bulge of the prolapse, but the constant urinary urgency and pain as well. You're taking the physical tension off those stretch receptors.
You are treating the root connective tissue failure rather than just addressing the downstream symptoms. Which brings us to the ultimate crossroads for the patient and the surgeon. The patient is prepped for surgery. The clinician knows, based on a severe bulging cystocele, that the patient needs a prolapse repair. And thanks to a carefully executed reduction stress test, the clinician also knows the patient has occult, hidden stress urinary incontinence.
The surgeon knows the hose is going to leak once it's unkinked. So what is the protocol? Do you perform a concomitant surgery or a staged surgery?
This raises an important question, and it's perhaps the most heavily debated, agonizing decision in urogynecology today. A concomitant surgery means the surgeon addresses both failures in a single operation. While they are actively lifting the prolapsed bladder, they simultaneously install a mid-urethral sling or perform a procedure like a Birch-Colpo suspension to support the urethra and artificially prevent the unmasked leaking before it ever starts.
I mean, if you know the incontinence is lurking there, why wouldn't you just fix both at the exact same time? The patient only undergoes general anesthesia once. They only have to navigate one painful recovery period, and they wake up with their structural prolapse resolved and their continence fully preserved. It sounds incredibly efficient.
The efficiency is undeniable. But treating a condition, prophylactically treating it before it has actually become a disruptive problem in the patient's daily life, carries profound medical risks. If pelvic floor surgeons routinely perform concomitant anti-incontinence surgeries on every single woman who tests positive for occult SUI in the clinic, a significant percentage of those women are going to receive a surgical sling they didn't actually need.
Because they might not actually leak.
Right, because even with a positive reduction stress test, not every woman will go on to experience bothersome leaking in her actual day-to-day life post-op.
And putting in a mid-urethral sling isn't just laying down a piece of harmless tape. We are talking about implanting synthetic mesh into highly sensitive pelvic tissue.
Exactly. Anti-incontinence surgeries carry their own specific and sometimes devastating complication profiles. By adding a sling, you introduce the risk of lower urinary tract injury during the placement. You can accidentally induce severe voiding dysfunction where the sling is pulled too tight and the woman goes from leaking to suddenly not being able to urinate at all. Furthermore, There is a very real risk of chronic, debilitating postoperative pelvic pain caused by the synthetic mesh itself eroding or contracting.
So if you perform a concomitant surgery on someone who ultimately wouldn't have leaked anyway, you have exposed them to the risk of chronic pain, organ injury, and voiding dysfunction for absolutely no medical benefit.
Exactly.
But if you choose the alternative, a stage surgery, you let the patient heal from the prolapse repair, send them home, wait to see if they actually start leaking in their daily life, and then only go back in for a sling if they truly need it.
But choosing the staged approach means you are forcing a woman who is already dealing with a major pelvic floor breakdown to potentially undergo a second major surgery, a second round of general anesthesia, and a second extended recovery away from her family or her job.
The psychological and physical burden of potentially facing two surgeries is immense.
It is a delicate, often agonizing balancing act. And this is exactly why the American Urological Association guidelines explicitly state that there is no one-size-fits-all clinical pathway. The standard of care has shifted heavily away from surgeon-dictated protocols toward highly individualized, shared decision-making.
So how do you actually make that shared decision? Does the doctor just lay out the pros and cons and ask the patient to guess?
Not quite. Clinicians now utilize sophisticated prediction models and algorithmic calculators. They input the patient's specific age, their body mass index, the exact anatomical stage of their pelvic organ prolapse, and the nuanced results of their pessary reduction tests right into these calculators. This generates a highly personalized statistical risk profile.
That's really cool.
It is. The physician then reviews the data with the patient, explaining that based on these specific metrics, her individual risk of developing unmasked incontinence is, for example, 60%. They discuss the concrete risks of implanting a prophylactic sling today versus the logistical and emotional risks of waiting and potentially needing a second surgery in 6 months. The patient then decides which set of risks aligns with her own quality of life goals.
So what does this all mean? If you're listening to this right now, the intricate mechanics of kinked urethras and trampoline springs might seem incredibly dense. But the reason you need to understand this mechanism is because knowledge is really the only defense against unexpected medical trauma.
Absolutely.
If you or a family member are ever sitting in a urogynecologist's office and the doctor says, you have a severe prolapse, we need to operate, you now have the tools to protect yourself. To ask, are we doing a reduction stress test today? What is my personal risk of de novo incontinence? What are the risks of doing a sling now versus later? Understanding that fixing one physical failure might unmask another empowers you to be an active participant in your own surgical planning, rather than waking up to a devastating surprise.
That empowerment is the most critical takeaway for any patient navigating these decisions. But, as we synthesize the literature, particularly Peter Petros's integral theory, it leaves us with a truly provocative thought about the future of this entire medical field.
Where does the integral theory take us next?
Well, we discussed how the root cause of both prolapse and incontinence is the breakdown of collagen and elastin in the pelvic connective tissues.
Right.
The springs of the trampoline losing their structural integrity, right? Right now, our only available solutions are purely mechanical. We go into an operating room and sew in synthetic meshes or plastic slings to act as artificial ligaments. But if the fundamental foundational issue is a biological degradation of collagen.
Then shouldn't the future of treatment be biological rather than mechanical?
Precisely. Could the future of urogynecology shift entirely away from the operating room? Instead of waiting decades for the pelvic organs to drop out of place and then tying them back up with synthetic tape, what if medical science focused on proactive biological therapies? We could be looking at a future involving targeted stem cell treatments, localized hormone therapies, or advanced tissue engineering designed to regenerate a woman's native collagen and elastin.
We could proactively rebuild the springs of the pelvic trampoline so it never has the chance to sag in the first place. No prolapse, no masked incontinence, no synthetic mesh. That is an incredible horizon to look toward. It just goes to show when you are looking at the murky, complex mechanics of the human body, sometimes you have to look past the surface-level symptoms and rethink the entire structural foundation from the ground up.
Thank you for joining us on this deep dive. Stay curious, ask the hard questions, and we will catch you next time.